I'm very honored to be here to share this topic. As we all know that CRT is just a very classic, conventional procedure, nearly have 25 or nearly 30 years old, not old, 30 years evidence of clinical practice. But now LBB pacing, or we call the conduction system pacing, has more and more data to show that in several kind of patients, LBB pacing may have a better clinical improvement than Bivp pacing. So how can we select these two different pacing strategies? So from the beginning, I just want to show you that for conduction system pacing, which implies direct activation of the conduction system, especially his-bundle pacing and LBB pacing. And because of the different anatomy for his-bundle, because it's quite narrow area, quite small area, so it's hard to have very good pacing parameters. However, for left bundle branch pacing, because of the anatomy, you can see from this ventricular septum from the left side. So it's from an animal model. You will see that the network is quite wide, and you can have very good pacing parameters if you can target to this area and screw the lead deep enough until the endomyocardium area. So for conduction system pacing, I mean, just for the electrical synchrony, LBB pacing can restore electrical synchrony in wide QRS, and also for the narrow QRS, it can also maintain synchrony. So that's why we will have this question: when should we take consideration to which CRT method should we have for a single patient? I think I will just get started from the de novo cases. If this patient just has the indication of CRT, which factors is the consideration why we choose LB pacing or conventional CRT? The first thing I think is the EKG parameters, especially LBBP morphology. As we know, in LBBP morphology, CRT is class 1 recommendation in this kind of cases. And we can still have the acute hemodynamic effect between LBB pacing and Bivp pacing. This small study just included the 21 patients with heart failure and LBBP, and both LBB pacing or Bivp pacing is provided during the procedure. And you will see that after AV optimization, Bivp pacing and also LBB pacing can increase the dp/dt max as compared to the baseline. But LBB pacing can further increase dp/dt max than Bivp pacing up to 6%, and it's quite significant difference between them. Also, is there any other clinical improvement between these two strategies? Yes, this is also a small observational study conducted in 4 centers. And you will see that we compared LBB pacing with Bivp pacing with adaptive algorithm to minimize the RV pacing. So for this adaptive CRT, we can have QRS duration reduction up to nearly 40 milliseconds, while for LBB pacing, after the procedure and AV delay optimization, LBB pacing can even more have a narrower QRS, and also for the LVEF improvement significantly higher than Bivp pacing. And for the super response rate, you will see that after 1 year follow-up, LBBP pacing can achieve super response rate over 60%, while Bivp pacing with adaptive algorithm just nearly 40%. Quite high and quite difference between the two groups. And another study also focused on the predict factors, which factors can predict higher, better echocardiographic response. You will see that among all these, like male age, gender, or ischemia or non-ischemia, all these baseline characteristics, just LBBP morphology can predict better echocardiographic response. And then we have several RCT now. For the first one is conducted by two Chinese center, Dr. Zhou and Dr. Fan, which is a very small RCT, just included 40 cases with non-ischemic sinus rhythm and LBBP patients. There are randomizations 1-to-1 to either LBB pacing group or Bivp pacing group. And you will see that all these two groups improved a lot as compared to the baseline. But still, at 6 months follow-up, LBB pacing can achieve even higher LVEF improvement than Bivp pacing. So, and this year, also another team in, I think in United States, they have another small RCT. It's a non-inferiority design, and a total of 134 patients was with CRT indications was randomized to Bivp pacing or CSP, and follow-up is 12 months. You will see that they include a lot of different kind of patients with CRT indication. Most of them, nearly, I think, nearly over 100, half of the patient is LBBP, and still they also include IVCD cases with QRS duration over 150, and small amount of patients with upper grade or AV block patient with LVEF less than 40. So let's see the result, because this is a non-inferiority design study. So the primary endpoint is nearly the same between the two groups after 1 year follow-up, and the non-inferiority was met in the two groups. So because this study has a different kind of a patient, not only LBBP, but IVCD and also pacing-dependent patient. So I think maybe the sample size is not too large, and for the follow-up, it's just 1 year. So it's just have the inferiority result. And here comes our RCT from 6 centers in China. This is called HeartSync LBBP trial, which was presented in this year's EHI for late break clinical trial. So we included 200 of cases with typical LBBP met with Strauss criteria. And there's very few of cases just cross over to the either group. And with median follow-up of 36 months, we see the result between the two groups. The QRS duration is nearly different. It's very different, I mean, significantly between two groups. LBBP has a significant narrower QRS than Bivp pacing. And for the response rate, these two groups nearly the same, over 80%. And for the super response rate, LBB pacing has a higher super response rate up to 65%. But this result, we should just focus on the baseline characteristics, because in our in this clinical trial, our patient is majority of our patients is non-ischemic. It account for more than 80%. So that's why the result is so different. And so I mean, the EF, the heart function improved both very significant, either in LBB pacing group or Bivp group. And for the primary endpoints, we can see that the LBB pacing just has a lower all-cause mortality or heart failure hospitalization than Bivp pacing. But if you just see the secondary endpoint of individual outcome of heart failure hospitalization or all-cause mortality, you will see that the most of the difference is between because of heart failure hospitalization, but for the mortality, there's no difference between the two groups. Then we know that LBBP may have better echocardiographic response to LBB pacing. But we know that for LBBP, there will be like different mechanisms. Here is a paper published in 2019, which shows that for the true LBBP, as we call it, left intrahepatic LBBP, we will see from this mapping at septal, you will see this is a complete conduction block. While for other LBBP-like ECG, which may have the mechanism of wide QRS, but still have the intact Purkinje conduction activation. So in this kind of cases, LBB pacing may have less effect than the true LBBP cases. So if we choose to see this mechanism or these true LBBP cases, that will be like just a proximal block at the trunk of LBB. So in this kind of cases, just conduction system pacing or LBB pacing maybe is enough to correct LBBP and to achieve left ventricular electrosynchrony. While if we cannot, I mean, do the LBBP successfully, or LBBP lead is not maybe not deep enough to get LBB capture, then we may have another chance for LOT CRT or Bivp-CRT in this situation. So while in IVCD cases, the story is totally different. Let me show you this study, just focus on the IVCD cases. Even this is a very small scale, the non-randomized observational study, we can show that for the QRS duration is quite wide, but it's not a typical LBBP morphology, and it is not completely corrected by his bound pacing, even with very high pacing output. Then we do LBB pacing. You will see at different output with different shape of RBBB shape, but still after LBB pacing, you will see that notch is still there and with very long LVAT up to 130 5 milliseconds. So at this time, we decide to add another CS lead. You will see that after the CS lead implantation and pacing together with LBB pacing lead, you will see the QRS duration get narrower than the LBB pacing only. And for this small study, we can show you the result that for after lot CRT, the QRS duration can even shorten, and LBB lot CRT group has a better outcome, especially the primary composite endpoint of mortality and hospital heart failure hospitalization than Bivp-CRT during 2 years follow-up. Then another group also have their lot CRT compare with Bivp-CRT or LBB pacing only for the hemodynamic assessment. So from this study, we can show you that yes, QRS duration is the narrower in lot CRT group and also Bivp group, but for just LBB only group, the QRS is not so narrowed. And for the DP-DT max improvement, lot CRT and Bivp-CRT nearly the same. They are all better than LBB pacing only. And from this hemodynamic study, we can show that lot CRT may have better hemodynamic effect in QRS wide over 171 milliseconds, and maybe more improved in ICM patient, ischemic patient. So here comes the IVCD mechanism. I think IVCD is more complex than LBBP. So some of the cases may just have a proximal block plus distal block. At this kind of cases, maybe LBB pacing plus CS lead may have further improvement than LBB only or Bivp only. But for the other mechanism like diffuse block, LBB pacing plus CS leads may have better. We don't know because we don't have more data. But from the mechanical mechanism, it may have a better improvement than LBB only. But for another kind of cases with distal block, I don't think LBB pacing can improve in these cases. Bivp pacing may have the effect on for these cases. Not only ECG before the procedure, we can find some predictive factor to the echocardiomyopathy. For the improvement of the procedure. Also, we still have a CMR assessment. And from these several small cases study, we can show you that higher scar percentage was associated with lower likelihood of echocardiographic and clinical response. And for the multivariate linear regression, the myocardial scar only in septum is strongly correlated with the change of LVEF. And this is another study focused on the CMR assessment. You will see that from these figures, with lower septal scar, Bivp pacing and LB pacing can also improve the LVEF, but LBB pacing may have a larger or more significant improvement than Bivp. However, in high septal scar patients, Bivp may have a trend of higher LVEF improvement. This is very interesting. For high septal scar patients, maybe we should choose Bivp pacing as a primary strategy, but the P wave is not so significant difference. We may need more data to include all these high scar volume patient. And for the long-term prognosis, there's no difference between high burden scar or low burden scar subgroups. And there's no difference between LBB pacing or Bivp pacing. So scar just have a poor prognosis no matter you choose Bivp pacing or LBB pacing. So I just finished the de novo case, but for upgrade cases like PICM or Bivp non-responders, which strategy can we use? For PICM cases, like we need to upgrade from the guidelines. Bivp pacing is class 1 recommendation, but CSP also have some small study to have the evidence of improved heart function. So here comes the small study. We can see that LVEF and LVEDD all significantly change in the two groups, but CSP has a higher increase than Bivp pacing. And both in LBB pacing and His-bound pacing, they can achieve similar LVEF increase. But we know that this is a very small scale study, just including maybe just include nearly 48 cases. This is another study just published, include also small scaled, including 78 patients. And at 6 months follow-up, LVEF can be improved in LBB pacing significantly higher than Bivp pacing. And during a follow-up of 20 months, there's no difference concerning on the clinical outcomes in the two groups. And for Bivp non-responders, we still have several small studies. Like this one is a non-randomized multi-center study. We can show that 145 CRT non-responders was included, but just 49 cases agreed to upgrade. Then we just upgrade in this patient and to do the 1-to-1 PS matching to have the nearly same baseline characteristics between two groups. And all these upgrade 44 cases, not all of them are responsive after upgrading. Just 21 cases becomes responders, and also the rest of 23 also no responders. And let's see the results. After upgrade, the QRS can be further narrowed after the procedure of upgrade, and also the clinical heart function like NYHA also has improved in the upgrade group. For LVEF, you can see that upgrade group have the higher LVEF than the control one. And for the primary outcome, also including this all-cause mortality, heart failure, hospitalization, and heart transplantation, showed significantly lower incidence of endpoint in LBB pacing group. And for all these upgrade cases, you will see that only LVEDV and baseline LBBP morphology are independent predicts of response after upgrading. That is to say, not all the cases we should do upgrading, because just half of them will be like responsive response after the procedure. So we need to choose to select several cases, especially LBBP morphology cases. So here comes the this year's ESC clinical consensus statement on indication for conduction system pacing. From guidelines or consensus, there's no doubt that for CRT indications, especially for LBBP, Bivp pacing still class 1 recommendation, and for non-LBBP, Bivp may just have class 2A recommendation, and CSP always lower than Bivp pacing in CRT indications. But for PISM, also the same thing. CSP just like may be appropriate to do, but Bivp is advised to do. For CS lead failure, CSP was advised to do, and for non-responders to Bivp, CSP is also maybe appropriate to do. So here is the consensus, or here's the guideline. I think they will be changing after more and more data comes. So here comes the summary. I mean, for this question, I think if you just focus on the guidelines, focus on the consensus, that's no doubt, because Bivp pacing should be always get higher recommendation class than LBB pacing. But why we have this question, I think guidelines always not so, I mean, we need to have more new data to support to changing the guideline. So that's why, that's the answer from my part now. First of all, LBBP morphology, especially typical LBBP met with Strauss criteria, and especially in non-ischemic patient, I think LBB pacing can achieve narrow QRS and higher clinical and echocardiographic response, especially higher super response than conventional Bivp-CRT. And for IVCD cases, I think that's we need more data, not only for CSP, but also for Bivp pacing, just focus on IVCD. Then LOT CRT might have a higher response rate than Bivp-CRT. And for the hemodynamic effect, both LBB, both LOT CRT and the Bivp-CRT may have a better than LBB-AP only. For the scars, I think high volume of septal scar is demonstrated to have worse clinical outcomes, no matter you choose LBB pacing or Bivp pacing. For PISM upgrade, I think from the guideline, and Bivp-CRT is class 1 recommendation, but upgrade to LBB pacing might have higher LVEF improvement than Bivp pacing, because LBB pacing may have a better QRS duration reduction than Bivp pacing. And for Bivp non-responders, it is appropriate to upgrade to LBB pacing, especially we need to focus on the baseline QRS morphology. If the patient is LBBP morphology cases, I think upgrade to LBB pacing might have a good result. Otherwise, if IVCD cases, there will be more complex, maybe LOT or maybe LBB only to correct the bundle branch block may have a better outcome. So here is my presentation. Thank you for your attention.